First up is Christine Schulman. She's going to talk to us about inflammation of critical illness and injury.
Thank you very much, and hats off to all of you diehards who are still here, braving the Friday afternoon and braving what lies await for you with traffic. So I'm very appreciative of you staying. Little disclaimer here, I really don't have any disclosures, but I do have a disclaimer, and that is, if I sound like I'm talking with slurred speech and all, it's because I've been so cold all day. I'm trying to speak between clenched teeth. So just maybe by being up here and moving around, I'll warm up a little bit. But I want to spend some time talking about the inflammatory response that results whenever a patient is injured. And I really became interested in this topic because we would frequently have patients where they got appropriate management of their injury and what seemed to be a reasonable time frame. And sometimes patients with really significant injuries did really well, and at other times patients with what were seemingly fairly minor injuries did terribly. And all the while, their injuries were managed appropriately. And I started to wonder, well, what's kind of up with that? You know, you have one patient who gets really bad ARDS, the next patient with equivalent injury doesn't. And so the reason this whole talk came together was to try and gain some kind of global understanding about the inflammatory responses that are kicked into gear when patients become ill or injured. And we all know that healing is really an inflammatory process. For every bit of inflammatory response we also have to have an anti-inflammatory response. Otherwise, we'd end up being one big flamed out inflammatory entity, and that's not what happens. We don't die every time we get a head cold. We don't die every time we have a paper cut. So what's up with that? We used to think that this inflammatory response was kind of a delayed physiologic response. It took a little while for it to truly gain momentum and to bloom. And while that may be true, we certainly know that the inflammatory response begins the moment an injury occurs or the moment there is an exposure to an offending bacterium. And while everybody has this, it becomes persistent and problematic in about a quarter to a third of our patients. Now, there's lots of processes going on here, but I'm going to put them into about 6 different mega categories. And one is just what happens when we have hyperperfused anaerobic tissues. Then we'll take a look at some of the inflammatory mediators and the catecholamine responses going on there, oxidative stress. We'll spend a little bit of time then on the subsequent reperfusion injury, what's going on in the gut, and then where the coagulation cascade kind of fits into all of this. And we're going to do all of that in about 35 minutes. The way I think about the inflammatory process is that it's kind of like a big old bear walking in the woods. Now, what do you know about a big old bear walking in the woods? Most of the time, he's just wandering around eating roots and grubs and not really getting into too much trouble. He's just kind of doing his thing. But on occasion, a bear becomes angered or threatened or becomes injured and is in pain. And what happens then? The bear becomes this virulent beast. It causes a whole lot of damage, and there's a threat of a whole lot more damage. And that is exactly what's going on with the inflammatory cascade. And most of the time, it's doing what it's supposed to do. But when it gets jazzed up because of a mega injury, a mega illness, or mega tissue damage, etc., then it becomes this virulent beast and becomes as much of a problem as the original insult was in the first place. So if we step back and take a look at this from kind of the 30,000-foot view, we would take this inflammatory process and the whole balancing act. We would look at it this way. It's been coined as the ebb phase and the flow phase. The ebb phase is those first hours up to maybe the first 48 hours where you know, all of your actions are to restore circulating volume, to restore oxygenation, to ventilate the patient, and to get perfusion restored. Those are it's the resuscitative phase. Now, if we've done our job and tissues are perfusing and there's a trickle of urine going down that Foley catheter and the patient's tachycardia slowly starts to resolve and we don't have to add more fluid boluses, we've got somebody who's stable and they can move forward in a couple different pathways. The first is the beginning of this acute phase, and this is a time when all of the hypermetabolic processes, all of the cytokines, catecholamines, and different hormones are completely in overdrive, where they're trying to regulate things, respond to that initial insult. And this is marked by things like an increased resting energy expenditure. There's some catabolism going on. You have elevated glucose because you have an accelerated gluconeogenesis process. And if you are measuring, you'll see that they have an increased oxygen consumption because they're really hypermetabolic because they're trying to put out the flames of their initial resuscitation. And if there are no additional insults, they move into the adaptive phase, which is the recovery and rebuilding, the true healing begins. But we have lots of patients where they don't just move in that linear fashion. Many times they'll suffer a second hit. A second hit might be the patient who has an MI after their trauma, the patient who has an anastomotic leak and has a septic belly and has to go back to the OR, the patient with the AAA who has now a bowel that is ischemic. These things make them suffer a secondary insult, which then either keeps them in this hypermetabolic phase, or it throws them all the way back into the resuscitative phase, and the clock starts all over again. And I think we need to be cognizant of the fact that a return to the OR for any reason, whether it's planned or unanticipated, is a secondary hit. Never forget the fact that surgery is, in fact, penetrating trauma. It just has a surgical permit that goes with it, right? And, you know, I was taken aback by the video there. I don't spend a lot of time in the OR, but I'm seeing surgeons rifling through the small bowel. I don't know what's not traumatic about that, right? So that's a secondary hit. And that secondary hit just keeps that inflammatory process going and going and going. So what then are some of the things going on at the closer view? And one of the things I want to talk about is the mediator response. We're all, as I said, this delicate balance between pro-inflammatory processes and anti-inflammatory processes. And unless you've had your head in a box for the last 20 years, we're pretty well aware of the SIRS response, that systemic inflammatory response syndrome. This is our pro-inflammatory response. It's our primary response to offending bacteria and damaged tissue, and it's really driven by all these inflammatory mediators and that whole antigen-antibody recognition system. It's our very best defense against bacteria and viruses and even fungi. What we don't spend a lot of time talking about is the CARS, the compensatory anti-inflammatory response syndrome. Here's where all those revved up white blood cells become deactivated. There are suppressive cytokines in activity here, and that whole antigen-antibody recognition system is starting to become blunted. And without CARS, we would not survive as individuals. So there has to be this balance. The way I like to think about it is that the whole cascade begins with activation of the SIRS. The predominant cells here are the helper 1 cells, the Th1 cells. These are converted CD4 cells. And they release a bunch of inflammatory cytokines in response to bacteria and viruses, things like tumor necrosis factor, some of the interleukins, that kind of thing. And the whole purpose there is to set up some opportunities for the white blood cells to do their work. Those inflammatory mediators dilate microcapillary beds so that white blood cells can get through them. Those activated white blood cells now release these substances that chew holes in the vascular endothelium so that the white blood cell can follow and get out to the bacteria that's sitting in the interstitial fluid or the damaged tissue. But they're chewing holes in the vascular endothelium. And they're so activated because it is these chemicals coming off of the surface of these white blood cells that go on to damage the cells of the bacteria. Now, they're not necessarily selective, so they tend to cause some damage to healthy cells that perpetuate more of an inflammatory process. And this is where we get the SIRS, is that we get this overzealous response from these hyperactive Th1 cells. To bring all of that into check is the CARs. The dominant cell here is differently modified CD4 cells. These are called helper 2 cells, cleverly enough. And these helper 2 cells are charged with mitigating that inflammatory response. So they release different inflammatory mediators that ultimately deactivate those white blood cells so that they stop doing their job, basically. And then everything settles back into homeostasis again. But either one of these, SIRS or CARs in excess, creates an immunologically vulnerable organism that would be you or your patient. And either one of these can put you in a downward spiral that make you vulnerable to secondary insult and certainly compromise your ability to respond to them. So there will be a post-test on this particular figure later. No, I'm really kidding, but not so much. The thing I like about diagrams like this is that it really brings into play how many processes are going on. And this kind of takes on a middle scope view of all of the different processes, inflammatory and otherwise, that ultimately result in hypoperfusion and organ dysfunction. And the visual effect I want people to walk away with is if you fix one pathway, that doesn't necessarily mean that the others are taken care of. So even when we find some novel therapy to address one of these arms, there's oftentimes unintended consequence with some of the other inflammatory arms. I think in particular about histamine 2 blockers, the H2 blockers, and if you're old enough, you remember when we gave Tagamet IV like candy. And why did we stop giving it? It's because we realized that those patients had increased incidence of sepsis. Now, we were preventing stress ulcers, but we were making our patients vulnerable to sepsis. Why? Because histamine is one of the first steps in the inflammatory process, and we were blocking it. And we think about our cancer patients, we're trying to stop the growth of these antigenic cells, but in the process, we blunt our response to antigenic bacteria, right? So we deal with this problem all the time. And ultimately, in the case of widespread indiscriminate vasodilation, capillary permeability, we're going to end up with a perpetuated inflammatory response that affects at the tissue at the cellular level. Well, now let's talk a little bit more about these catecholamine responses and get a little bit more specific. And yep, I'm talking about the fight or flight syndrome here, but in a different way than what we typically think about. You know, we started to learn about this in the late 1800s when the ground-up adrenal glands of animals were injected into the muscle of same or related animals, and the response to that was that there was an increase in heart rate and blood pressure, and there was also an increase in lymphocytes and granulocytes. And it was such a remarkable physiologic response that they called it, suprarenin, wanting to be really melodramatic about the whole thing. And then a few years later, they developed the crystalline form that we've come to call adrenaline. And over the decades, they identified norepi. okay? Now, I think the real step forward in terms of our clinical practice was in the 1950s when they developed an intravenous formulary of this, and they injected it into the veins first of animals, but then in healthy human volunteers. And they saw the same response. Within 5 minutes, there was an increase in heart rate and blood pressure, but there was also an increase in lymphocytes and granulocytes. And hence the beginning of epiboluses and epinephrine drips and all of that has followed. The thing is the question is, where did these lymphocytes come from? Because they could even see this increased count in these white blood cells when patients had had splenectomy, meaning that the big reservoir of these had been removed. And yet these patients could still have this kind of a response. Where did that come from? Well, here's what they've uncovered. They've uncovered what they call this marginal pool of lymphocytes. And what happens is that in response to circulating catecholamines, there is an entire reservoir of these lymphocytes that normally lay embedded in your vascular endothelium, and in response to the circulating catecholamines, they mobilize into your bloodstream. So what a wonderful design that is you've got catecholamines running around saying, danger, 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 I need help, I need the infantry here to fight the fight, and out of the vascular endothelium, in fact, comes the infantry in the form of lymphocytes. And they're very sensitized, and they're those Th1 helper cells. They are promoting and exaggerating an inflammatory response, which is exactly what we want. And they have been able to demonstrate that this happens not just in physiologic insults, but in other more social contexts. They've done some studies of people jumping out of airplanes. They measure their white blood cell counts and their blood pressure and their heart rates before they jump out and after they jump out, and they find a big surge in all of these things. So they're not measuring sphincter tone, but I think that might be a good stress test to evaluate. Did you know that the number one fear that most adults have is they have a fear of speaking in front of groups? So I would venture to say that this man doesn't have that physiologic response, but a lot of people, when they're getting ready to speak in front of a group, they get the shakes, they're tachycardic, they're blotched in the neck. And how do they manage that if it's kind of a crippling thing for them, and yet they have to keep doing it? What do they take legally? Beta blockers. They'll take a little Inderal, one-time dose, to kind of bring those shakes under control. Okay? And then we also know that athletes do this, that during their physical activity, of course, their heart rate and blood pressure go up, but also their white blood cell counts go up. If you've worked in the emergency department, you know that if somebody just drops a box on their foot, their white blood cell count is up. And that is a physiologic stress response because the infantry has come out to fight the fight. I think this goes a long way towards explaining why. Now, I don't know this for sure. There's probably studies to this. But in my mind, it makes sense to me that people who exercise regularly tend to become sick less often because they have a regular scavenging of offending bacteria, right? Other than people who don't exercise, there's probably multifactorial causes there, but I'm wondering if there isn't a physiologic correlation there. Now, one of the things we also know about this is that the longer you are exposed to these processes and these inflammatory mediators, as helpful as they are in the beginning, they actually become immunosuppressive over time. They lose some of their effect and, in fact, even establish some more harmful, directly immunosuppressive activities. This is where the CAR system is starting to take over. And you see decreased tumor recognition, you see decreased recognition to viruses and bacteria. You see a lot of things. Clinically, you might have the head-injured patient who has one infection infection after the other, after another, after another. Yes, he's vulnerable, but he's doubly vulnerable because his immunosuppressive activity is compromised. I think this also goes a long way towards why people who've undergone a whole lot of stress for a period of time, they tend to get really sick with head colds and cancers and things like that, because their whole immune recognition system is off kilter over time. Another process of the inflammatory cascade is oxidative stress, and what happens when those toxic oxygen molecules get reperfused. So we know that aging cells in particular, as they die off, they release these reactive oxygen intermediates. These are the oxygen free radicals, the hydroxyl molecules. But certainly this process is accelerated in scenarios where there's limb ischemia, where there's been an MI and other organ ischemias, hypovolemia, hypovolemic shock, and reperfusion injuries. There is a big bolus release of these toxic oxygen molecules. Now, these molecules that come off aren't intended to necessarily be damaging, they just happen to be damaging. And there are processes normally to scavenge them up. But in these accelerated situations, they are not being scavenged, and they're causing a lot of downstream inflammatory process. We know that these oxygen molecules are toxic. And then when we resuscitate them, then they just get perfused all around the body, and they cause some downstream inflammatory processes. Key number one would be in the lungs and in the kidneys, acute lung injury and acute kidney injury. What is happening here is that those normal antioxidant processes are being overwhelmed. They can't keep up. And so downstream responses from these toxic oxygen molecules are things where cellular proteins are being broken down, cell walls are being broken down, and the fats of those cell walls are being broken down, and that establishes some of the arachidonic acid cascade, also an inflammatory process, and other signaling to inflammatory mediators. So now you just have, chaos going on. And you think about the crush injury patients who've had a heavy wall on top of them. When the wall is released or the tunnel is taken off of them, they're unburied. We're not supposed to fluid resuscitate them aggressively because you have inflammatory mediators going around. Or the found downer who's been down for a day and a half. When they come in, they're dehydrated, but we have to be very careful about how we do that because we're going to wash out all of these toxic molecules and acids, et cetera, that set about additional inflammatory responses. The normal balance of these mechanisms are these different antioxidants responses. Some of them are enzymatic, and most of us haven't heard of them, but others of them are really familiar to us. Things like vitamin E and C that you can buy over the counter. Other dietary substances like vitamin A and beta-carotene. But other processes that and substances in our body actually are free radical scavengers. And so normally these kinds of things are held in check, but in our trauma scenario, they're out of balance. Another source of inflammation here is the gut. Now this is a day's worth of lectures in and of itself. So I'm just hitting the tip of the iceberg here. But we better be grateful for the fact that our gut is responsible for about 65 to 75% of our overall immune function because it is full of bacteria. And the vast majority of those bacteria have the potential to be harmful for us, but they're actually held in check, really, by the healthy obligate anaerobes, kind of what I refer to as the good guys. The thing about the pathogenic bacteria is that they could release enough endotoxin to kill us all several times over. So there's got to be a lot of immunocompetence going on in the GI tract. It's a shift in our thinking to broaden our respect for the GI tract, to take it from just merely a hollow conduit that metabolizes nutrients and fluids and electrolytes to one that also protects us from bacteria and associated toxins. To bring this concept just into crystal clear vision, let me ask you this. How many of you own a dog? Yeah. And how many of you, these are my dogs, how many of you have watched said dog eat something it should not? You know, dead squirrel, dirty diaper, you can hear him snuffling around in the cat box, you know. And how many times does that dog actually ever get sick? Yeah, not so much. You might get sick dealing with that whole situation, but the dog doesn't get sick. Why? Because the dogs are carnivores. They have evolved as a species because they eat dead things and they don't die. They have short GI tracts and really impressive livers. So on a lighter scale, let's talk about that in humans. As I talked about, we have the good guys and the bad guys in the GI tract, and in today's vernacular, this is referred to as the gut microbiome. This is the community of bacteria that reside in symbiosis in your GI tract to break down nutrients and not do any harm. And they, like I said, they have this synergistic effect with each other a lot. Now, if anything happens in the GI tract to shift that balance in the community such that the pathogenic have a dominant presence and some of the healthy obligate anaerobes are not able to mitigate that, then we have problems like, C. difficile, for example, okay? The other thing going on in the GI tract that's really protective as an immune function is that mucus that's in the GI tract. The mucosal cells in the GI tract release mucus, and the substance itself kind of provides a protective barrier, and it kind of provides a slick substance so that food boluses can move their way on through. But the other thing about mucus is that it includes peptides as well as immunoglobulin A, and those have really impressive immunological function. The IgA ultimately is working with our lymphocytes to sensitize them and help them decide where they want to live when they grow up. And those sensitized lymphocytes go live in the respiratory tract and in the mammary glands and in your sinuses and in your GI tract, and they sit lying in wait for exposure to antigens that are going to be offensive. It's how you start to wheeze when you eat strawberries or you eat yeast and that kind of stuff, all right? It's a lifelong process. So that IgA is really critical in that whole step. We have peristalsis, and peristalsis, as you know, is moving a bolus of food all the way through the GI tract. Takes about 33 hours for food to move from the beginning of the small intestine, to move through the large intestine, and it's different for men and women. I don't know what that means, but that's probably a study in and of itself. But in the whole purpose of this is for the geographic location that is specific to pulling off fluids and electrolytes, but also to keep the bolus of food that is full of bacteria moving so that the bacteria don't have time to adhere to the intestinal epithelium and make breach into the vascular space. You'll also remember from anatomy and physiology that the cells of the intestinal lumen, the epithelial cells, are tall and columnar. Do you remember that? And they're following the whole surface of the GI tract and the villi. So increased surface area to maximize absorption of fluids and nutrients, but also they're tight like this. They're held together by these peptides called tight junctions Now, these junctions are very dynamic. They'll open in response to certain nutrient signals, but also in response to ischemia. So what is also very tight, they will open. And it opens selectively to let nutrients and fluids through, medications through, and in the case of opportunistic bacteria that are moving too slowly or are too virulent, they will open up. And then the fluid, the bacteria move through that epithelial space, they cross into the interstitial fluid, and sometimes they can even move all the way into open capillary beds. So have you ever had the experience of culturing a patient and culturing them and doing blood cultures, and they're septic as a dog, but you can't really, you finally get a positive blood culture? This might be one of the pathways for that, is that there was opening and permeability of the intestinal barrier. And, they didn't aspirate and they got good Foley care, but there was a breach because of the hypotensive moment that allowed the gut to be vulnerable. Okay? So that cellular barrier is really important. One of the things we've learned is that the mucosal cells in the GI tract, they actually start to atrophy within hours of not being exposed to nutrients. So you may remember that there's tissue in the GI tract called gut-associated lymphoid tissue, and in that there's things like Peyer's patches and patches of lymph cells and those kinds of things. We know that the reason that the various lymph tissue in the GI tract is supported over time is by being exposed to nutrients. And if a patient is not receiving nutrition for 24 hours, some of those lymph patches start to atrophy. And we find decreased mucosal cell activity in the lungs and in some of those other areas where there's a lot of mucosal tissue. And then finally, there's the whole gut-liver axis. The gut is really resilient, the liver even more so. There are inherent defenses against endotoxins, one of which is bile. Bile forms kind of detergent-like substances, or has detergent-like substances within it that actually deactivate the endotoxin coming off of bacteria. And if you'll recall that bile is secreted into the GI tract very high up in the small bowel, in the duodenum, it is continuous throughout the rest of the GI tract. If you have a patient who, for whatever reason, is not making bile, this protective function is compromised for sure. We also have these Kupffer cells that sit in the liver around the perivascular areas, and they're just waiting for bacteria that has made it, that has breached through the intestinal barrier, has gotten into interstitial fluid, has made it into the circulatory space of the superior mesenteric vein, the inferior mesenteric vein, and are coming together in the portal vein and coming through the liver, and those Kupffer cells are right there as kind of a last firewall of protection. They're great big macrophages, and they chew up bacteria and they deactivate some of the endotoxins. So if you have a patient with liver failure who's septic, and then they're septic, and then they're septic again, and then, maybe tomorrow they're going to be septic too, one of the reasons for this is that their liver isn't doing that last-ditch cleanup. And then, lastly, I want to talk about some of the consequences here of the gut stress, because we know that if we don't use the gut, it starts to atrophy, the tissue junctions, the tight junctions start to open up. We get that permeability. There can also be increased oxidative stress. All of these things allow pro-inflammatory processes to take over. And then that is further exacerbated by the microbiome being off kilter. And we do so many things clinically to make this even worse. We immunosuppress them with chemotherapeutic agents and steroids. We put them on antibiotics, sometimes not the right ones, sometimes for not the right amount of time. Maybe the bacteria are particularly resilient, the ones that are causing our clinical problem, but all the other innocent bystander, good guy bacteria are compromised. We affect the pH in the GI tract, and we know, for example, when we give omeprazole, there's sometimes an overgrowth of the bacteria in the small bowel that results in some diarrhea, more common in elderly patients. Ileus and all of the things that we do to cause it, like opioids, paralysis, immobility, etc., slow down peristalsis so that bacteria have more time to breach. And the catch-22 of patients needing vasoactive agents when they're hypotensive, but that prolonged exposure to a catecholamine agent can in fact cause immunosuppression, and also sometimes the doses we need to achieve the blood pressure that we seek cause blue fingers and toes, and if fingers and toes are blue, so are the GI tract. So it's a catch-22 with pressors. The last thing I want to talk about here is the role of the inflammatory cascade on the coagulation cascade. Now, well, this kind of makes my eyes spin around counterclockwise in my head, but simply put, these two processes are intimately connected. You know, histamine is part of both. Complement is part of both. And if you follow the diagram here, you can see the offending organisms on the left. They cause the white blood cells to respond. The white blood cells become activated. They release their inflammatory mediators, all of which are designed to damage some of the bacteria, but they also can cause some damage to the vascular endothelium. Now, the purpose of that is to allow the bacteria, the white blood cells, to get out to bacteria. The unintended consequence is that you're releasing something called tissue factor, which is embedded in the vascular endothelium. And that is a powerful anticoagulant, so the natural response to that is a pro-coagulant response. Remember this morning, Dr. Bernard talked about how ultimately this pro-inflammatory state makes us pro-coagulant. And so now I've got this pro-coagulant process going on, and eventually I have to be able to break it down. But the purpose of that microvascular coagulation is to contain damage, right? But when in excess, we get coagulation and further ischemia, and when insufficient, we have inability to clot, and we have over-exuberant fibrinolysis. So in sum, we've got SIRS, we've got CARS, we've got catecholamine responses, oxidative stress, gut response, and the whole coagulation cascade. This is all supposed to bring things into balance, but sometimes it is harmful. And the patients we see doing this, they're the ones with ARDS and acute kidney injury and secondary brain injury and gut failure and sepsis and sepsis and sepsis. Now, our battle strategies for this are complicated and ever-changing. One is timely and adequate resuscitation using the right parameters to assess and the right fluids and substances to resuscitate with. We're not going to talk about that. I'm running out of time. We're going to just briefly talk about gut support. Enteral nutrition, we need to feed the gut. We need to feed the bear. We need to be intelligent about how we do it, and we need to do it not only at the right time, but with the right substances. There's too much literature out there that tells us that supporting the GI tract has lots of benefits to our immunological function, and ultimately ICU length of stays, hospital length of stays, wound healing, and improved mortality. One of the things we need to be aware of is that we got to feed patients, but the question is, when do we do that? And there is some thinking that if you feed this inflammatory process sugar and protein and et cetera, you will fuel it. So the thinking currently is that you wait until resuscitation is complete. In other words, you're not adding fluids, you're not adding pressors. Your patient is making some urine, the vitals have stabilized. And when you're at the point of weaning back pressors, they don't have to be off, but you're weaning them back, you can start feeding them. But you don't do it to their full caloric demand. You do it about 1/3 or 2/3 of their caloric demand, and then you slowly increase to goal at that point. And then you can feed in a regular NG tube, even if you're doing 10 or 20 cc's. So I've spoken with people who sat on the SCCM guidelines for enteral nutrition in the critically ill, and even the 10 or 20 cc's is enough to supply nutrients to support the gullet tissue and the GI tract. So you're not meeting their nutritional needs, you're supporting their immunological needs by even just trickle feeds. And trickling saline or dextrose solution down there isn't it. It is a little bit of enteral formula. In those formulas, what do we put in them? And what do we do? Meanwhile, that is subject of great research, but some of the more popular notions are supporting antioxidants, so vitamin E and C, well established. They have a symbiotic relationship in terms of free radical scavenging, and there's a few studies out there that continue to be cited in the literature as mainstay justification for using these. But as with all good things, you can't use too much. Okay, a little bit of a good thing is great. A lot of a good thing doesn't necessarily make it better. There are other immune-enhancing nutrients that we need to use. We don't know which ones. There is hopeful evidence coming forward as to some of these other subjects, but we don't really know where we stand with them. And probably one of the biggest areas for this is around the use of lipids. We've been hearing for the last couple decades that lipids are evil. But in listening to Bob Martindale speak about this at SCCM, it isn't that lipids are evil. It's that some perhaps are evil, and that the ones we were using 20 years ago to come up with these conclusions are not the right ones to use. Europe has been infusing fish oil to good effect. We're looking at giving flaxseed oil and coconut oil in different combinations and in different time frames. So stay tuned to hear how this evolves over time. The last thing I want to talk about, though, is the use of probiotics. Now, probiotics have been around since the dawn of time, really. These are bacteria that exist already in the human GI tract. They're very stable there, and they serve to create that good community in the GI tract. So these are things that are oftentimes very familiar to us. If you just take a look at a yogurt container or a kefir container, you'll see some of these bacteria listed there. But there are studies that demonstrate benefit from clinical benefit in the ICU from the use of probiotics. Now, it's not an open season on them. We still don't really know how and when to use them, but we do know that by establishing or attempting to reestablish a normal microbiome, we will inhibit some of the pathogenic bacteria, will stabilize the epithelial wall, the lymphoid tissues are better supported, and all of those things that we talked about earlier. Lots of questions still exist there. You know, is it which strains of it are the best? At what time frames? How much? When is it a problem? When do we not give it? Up at OHSU in Portland, where Bob Martindale, the trauma surgeon who's the lead author on the SCCM guidelines, and across the river where I work at Legacy, all of our patients get some kind of probiotic. They either get, if they take trays, they get a little bit of yogurt on their cart, and if they got feeding tubes, they'll get kefir down the feeding tube 3 times a day. And I got to tell you from personal experience, if you ever have a long-haired dog with diarrhea on antibiotics, a little bit of yogurt in their food is not too much to pay for. I'll just say this about that. So very much a whirlwind tour, complicated topic. Immunocompetence is probably where the state of the science is for most medicine these days. It behooves us to stay very well informed. All of resuscitation and all of the secondary effects of shock have to do with inflammatory processes, and our strategies for mitigating that insult in the first place and then trying to get control of the downstream consequences are where all the action is these days. So thank you very much for your time and your attention and the invitation.